introduce people. We're going to be recording this today's session, and because we know that there are a lot of people who can't make it today who would like to view what we're talking about today. So we do encourage questions during the presentation, but if there are personal questions, things that you don't feel comfortable asking about during the recorded time, at the end we will allow time for some other questions if they have personal items or matters involved. So let me begin. My name is Jonathan Schwab. I'm one of the pediatricians at Northampton Area Pediatrics, and we're talking today about depression and isolation. And this is one of the many series of parenting workshops that we've been doing over the many years to help parents understand some of the most common problems that children are experiencing, and things that we don't have as much time in the exam rooms or at other times to talk to our parents about, but we would like to help with. One of the things that we've been doing this for years is that it's very practical, we hope, and that it helps you see things that you are dealing with on an almost daily basis. We realize that you don't have the time to talk and ask questions at those visits that you have, but we do encourage you to use this as an interactive session if possible. Today's topic on depression and isolation is particularly timely because, as everybody is aware, we're still in a pandemic, and more studies are showing that children and adolescents are being affected by this pandemic through behavioral health problems, even more so than the actual virus infection itself. So today I'm joined by Adam Blackburn, who's one of our behavioral health clinicians, who's going to help us understand what depression is and how we can help children and teens who have this problem. A couple of housekeeping items, though. If you do have questions, please use the chat initially, and I'll monitor that, and I can interrupt Adam at the time when you're asking the question at a time where he pauses. So feel free, please, to use the chat and to ask questions. After Adam talks about the kinds of things that a behavioral health consultant does, I'll spend a few minutes talking about what a provider does to help children and teens with depression, which involves evaluation and treatment. So let's start with Adam. Thanks for joining us, Adam.
Sure. Happy to be here. Let me just get my PowerPoint going. Today we'll be talking about depression and teens and children, and just a little bit about myself. I've been at NAP for since 2020. Almost 3 years, started in the fall of 2020 and worked briefly at ServiceNet before that, but became licensed as a licensed marriage family therapist in California in 2004, got my master's in 1998, and throughout my career, I've worked in early childhood mental health. I've also worked in the adult population, in inpatient hospital and outpatient hospital programs, partial hospitalization programs. But I'm happy to be here at NAP, and I'm glad to be able to talk about this with you. What we're just sort of an overview of what we're going to be discussing today. I'm going to do an overview of depression, symptoms, signs, typical diagnostic criteria, and then specifically talk about self-harm and suicide with an aspect of how parents and caregivers can handle talking and intervening and helping their children in these cases. As Dr. Schwab mentioned, he'll discuss medications, and then also I'll finish it off with the other aspects of treatment options and share some resources for both depression and suicide and self-harm. And then we'll have time for questions at the end. So where are we now? Well, as Dr. Schwab mentioned, we are seeing an increase in mental health concerns across the board, but specifically depression is seems to be rising in children and teens. This comes from Mental Health America website, and 15% of youth is reporting suffering from at least one major depressive episode in the last year. This was 2022, I believe, that this information came from. Or sorry, 2021. And one of the main reasons to talk about this is that it is true that childhood depression is more likely to turn into adulthood depression if gone untreated. So this is an overview of where I got this information. And this sort of shows the depression across the country, from lowest incident to highest. And here in Massachusetts, we're sort of right in the middle there. These are youth with at least one major depressive episode occurring in the year. So childhood and adolescent depression is obviously different than normal blues and everyday emotions that children go through as they develop. Just because a child seems sad does not necessarily mean they have significant depression. I say this because, you know, as we go through this presentation, there may be things you see that, you know, that you can attribute to your child, and in of itself, these behaviors and warning signs don't always signal depression or suicidal thoughts, but we kind of put them together to make a bigger picture to understand what's going on. So also in talking specifically about adolescent and childhood depression, it tends to manifest itself differently than adult depression, with the main symptom being kids becoming defiant and irritable. And this is a problem in some cases because kids can get labeled as troublemakers. They're angry and they're not sure how to articulate their emotions. They get identified as troublemakers, and this in turn stops them from getting the help they need. Conversely, it can also be lack of emotions, appearing flat, apathetic. Now, again, you know, teens and kids go through angry, grumpy phases, and a lot of teens are sort of not putting their emotions out there. So again, I say that as a caveat. But if the sadness becomes persistent and is interfering with normal social activities, interests, schoolwork, family life, then we want to look at depression as something that might be happening. So let's talk about some myths. A lot of these are common myths, some of them not very common anymore, but you know, still worth mentioning. One is that it's not a real illness, and it absolutely is a real illness. And you know, just like a medical illness can be treated, and awareness and prevention and learning about how to manage it can be most effective. And some people, depression is a lifelong illness, but that doesn't necessarily mean that each episode is as devastating. And so that's part of learning about it and educating yourself and having your family educated about how you manage the symptoms that you have. Dr. Schwab will talk about medications, but you know, there is no magic pill. Antidepressants cannot cure depression, but they certainly are part of the intervention, and they're really important aspect of it. Depression is not about laziness, and it's not only someone just feeling sad. We'll talk about the causes and where depression can come from. It can be genetic, but just because it's in your family doesn't necessarily mean someone will get depression. And most importantly, talking makes it worse. In fact, talking is and expressing some of the feelings that are internalized is really crucial and important to managing it. So we'll talk about different types of depression in terms of the diagnostic criteria. The most common being, or the most prevalent being major depressive disorder, with these symptoms appearing for at least 2 weeks, sad or irritable mood for most of the day or nearly every day, loss of interest in activities, low mood represents distinct change from previous functioning. And so that can be sudden, it can be gradual. And then the symptoms that many of us are aware of, decrease in appetite, decrease or increase in sleeping, energy, poor concentration, feelings of worthlessness, extreme guilt, and of course the loss of desire to live, which we'll talk about later. And problems must cause distress or impairment in their home, school, or peers to be diagnosed as a psychiatric disorder. This is what is known as dysthymia, but now also called persistent depressive disorder, which is less severe than major depression, but tends to last longer. And it's characterized by a depressed or irritable mood for most of the day, more days, for at least a year. Problems with eating, same kind of symptoms. To be diagnosed, the problem must occur in more than one area of their life, school, friends, home. And there's about equal in terms of boys and girls that seem to experience persistent depressive disorder. This is a newer diagnosis called disruptive mood dysregulation disorder, characterized by persistent angry or irritable mood most of the day, nearly every day. The mood is punctuated by severe repeated temper outbursts involving verbal or physical aggression, greatly out of proportion to the precipitating situation and not typical of their peers. Must be present for at least a year and occur in at least two of three settings, and it tends to be more common in boys than girls. Unspecified depressive disorder, when they don't kind of fall into a category, but some of the features exist. This may be sometimes a temporary differential diagnosis or a way of sort of explaining some of the symptoms without quite meeting criteria for one of the other diagnoses mentioned. And then also worth mentioning, because of where we live, seasonal depression or seasonal affect disorder. You may have heard this before. It's less common in children and teens. It's more common in adults, but it does occur in children. And so it often, the mood changes with the weather. And most common, it happens during the winter, but it can also happen during the summer. And then also substance abuse mood disorder, specifically when from use or trying to stop use of alcohol or drugs, the depression can occur. So here are some common symptoms. I'll go back and forth, but for teens and children, what seems to be most prevalent in teens is more kind of pessimism, hopelessness, affecting sleep, losing interest in activities. And with children, I think one of the more common symptoms seem to be vocal outbursts, crying, being sensitive to rejection, and specifically physical complaints, having stomach aches, headaches that aren't explained by any kind of medical treatment or diagnosis. So I don't know if I went too fast or not, but I can come back to these too as well if you want. So the next section, we're going to talk about suicide and self-harm. And here are some common myths around self-harm and suicide. First being, talking about suicide increases the chance a person will act on it. We know this not to be true. That in fact, as mentioned before, one of the prevalent aspects of depression is feeling isolated and feeling alone. And so that the feelings that are kept inside are difficult to express. And many kids and teens, based on their experience or where they're at, they may feel shame or guilt talking about this and talking about having suicidal thoughts or self-harm thoughts. And in fact, getting a dialogue going is one of the best ways to really identify what's going on with them. Obviously, it's not true that people who talk about suicide are just seeking attention. We always take that very seriously. And even if it's not even if it's what we call passive suicidal ideation, it still merits talking about and taking very seriously and intervening before it could become worse. Another myth is suicide can't be prevented, or it can always be predicted. Is not true at all. And we'll talk about risk signs and risk factors and protective factors as well. A big one that hopefully is not as prevalent now is people who take their own lives are selfish, cowards, or weak. Another interesting myth, I think, is that this idea that teenagers and college students are at the most risk for suicide. In fact, while obviously it is a great concern in our nation, the highest population at risk is adults over the age of 50. And then another common myth is that barriers to bridges, safe firearm storage, other actions to reduce access to lethal methods of suicide don't work. In fact, some of the research that I looked at indicated that while suicide hasn't substantially increased overall for this age group for teenagers, the lethality, the methods that they're choosing are more lethal, and so that more teenagers are dying from suicide attempts. And so these actions that we can take to provide barriers can really make a difference. So suicide and self-harm, I'm going to talk about the differences between them. Self-harm can be characterized as an ineffective coping method that someone might develop when they're experiencing intense negative emotions, or because of depression, they feel numbness, emptiness, and they're trying to access some feeling. A common method of self-harm for many teens is cutting, self-injury through cutting themselves. And what is sometimes articulated is this sort of feels like a release to them. Sometimes it can be to avoid certain social situations or stressors, and sometimes it can be to get a way of trying to get help and not knowing how to ask for it. Self-harm does not always correlate with wanting to die. Just because a teen is engaging in self-harm doesn't necessarily mean they have suicidal thoughts or that they want to die. However, it is a risk factor, and a very concerning risk factor, as I'll mention in a moment. But the main difference that we're distinguishing between self-harm and suicide is intent. So here's some similar risk factors between suicide and self-harm. History of trauma, abuse, chronic stress, high emotional perception and sensitivity, few effective mechanisms for dealing with emotional stress. So low coping skills or ineffective coping skills, feelings of isolation. And it's important to note that this can be true for people who seem to have many friends and connections. Again, depression can be sort of an inward, isolated feeling, and it could be that the person has lots of friends, but they're not talking about what's going on, and they have a supportive family, but they're not expressing what's going on inside. Alcohol or substance abuse can be a risk factor, and the presence of depression or anxiety, obviously, and feelings of worthlessness. And as I mentioned, self-harm can then also be a risk factor if teens are engaging in it, although it doesn't necessarily, like I said before, mean that they are feeling suicidal because they're doing it. So there's no single cause for why someone becomes suicidal. Suicidal thoughts often occur when stressors and health issues converge to create an experience of hopelessness, despair. Depression is the most common condition associated with suicide, although it's not the only one. And it being undiagnosed or untreated obviously puts the person at a higher risk. Conditions like depression, anxiety, substance abuse, when unaddressed, increase the risk. So here are some risk factors. In terms of health, we're looking at mental health, any kind of mental health diagnosis. Again, depression being the most prevalent, but anxiety or a combination of mental health stressors and diagnoses can increase the risk. Physical health conditions, chronic illness, which includes physical pain, traumatic brain injury. Environmental risk factors, access to lethal means, including firearms and medications, prolonged stress, such as harassment, bullying, relationship problems, feelings of loss or rejection, experiencing loss or rejection, poor academic performance or intense academic pressure, stressful life events, rejection through a breakup or family school crisis, other transitions or loss, exposure to another person's suicide or to graphic or sensationalized accounts of suicide. I think there are trends that we're aware of as parents and professionals of instances of teens glamorizing suicide, romanticizing it, or in certain TV shows. Now, again, watching something like that in and of itself does not necessarily put someone at risk for suicide, but if they're already thinking about it and they are experiencing chronic depression and intermittent suicidal ideation, then that is a risk factor. Historical, when us as professionals, when we're assessing suicide, we're always wanting to know, have they attempted suicide before? Puts them at very high risk. They have family history, especially if they're someone in the family recently or a friend recently attempted or committed suicide, childhood abuse, neglect, or trauma. So let's talk about warning signs now. We're looking for a change in the presence or the presence of entirely new behaviors. The sharpest concern if behavior is related to a painful event, loss, or change, and associated with diagnosis of depression or mental health diagnosis. Most people who take their lives exhibit one or more warning signs, either through what they say or what they do. So behaviors that we want to look out for are increased use of alcohol or drugs, looking for ways to end their lives, researching online for methods, withdrawing from activities, from family, from friends, increased irritability or pushing people away with the behavior. So withdrawing may not just be sort of quiet withdrawing, it may be an angry, irritable withdrawing by becoming more antagonistic with the people that they care about. Sudden or gradual changes in academic performance, focusing on morbid and negative themes, death and dying, giving away possessions that are valued, like I said, increased aggression, I mentioned before, fatigue, increased crying, all of these. The mood, we're looking for depression, anxiety, loss of interest, irritability, humiliation, shame, anger, increased agitation, and what I mean by relief or sudden improvement. Sometimes a high risk time for someone with depression that's having suicidal ideation is when they go from more major depression, where they are doing less and able to do less and more in a depressed state, to having more increased energy all of a sudden through whatever might bring that about. And so that is a time that we are going to be concerned if all of a sudden they have more energy, but they're still having suicidal ideation that they're dealing with. Things that they might say that we want to worry about. Yeah, obviously, if someone's talking about killing themselves, that's the highest concern. If they have a narrative of feeling hopeless or having no reason to live, if they are saying people would be better off without them, or feeling like they're a burden to others, if they are feeling trapped in a situation and they can't see any way out, and obviously unbearable pain, emotional pain. I mean, it could be physical as well, as I mentioned, but also in many cases, depression produces an emotional or psychic pain that the person experiences. Let's talk about protective factors. Access to mental health care resources, therapists, groups, feeling connected in their community, with friends and family, open communication and dialogue in the family about emotions, about things that, even difficult feelings, difficult emotions, increased problem solving and coping skills, limiting access to lethal means, and cultural and religious organizations or communities that promote help seeking and discourage self-harm and suicidal ideation, and offer support in that capacity. So what can parents and caregivers do? So I want to acknowledge, that this is really scary stuff that we're talking about, and it's completely understandable that as a parent or caregiver, it stirs up a myriad of emotions and feelings when you hear that your child is harming themselves, or having thoughts of harming themselves, or wanting to die. And the gamut of emotions, it obviously scary, produces a lot of anxiety. We may feel guilty. What did we do wrong? Why is our child feeling this way? Blaming ourselves. We may want to avoid it because it's just really uncomfortable and makes us fearful. It could activate us based on our own histories, or it could make us angry and accusatory and want to say, why do you feel this way? Why do you want to kill yourself? You have so much to live for. I love you so much. All those feelings are valid and real. And it's important that when parents are going through this, or caregivers are going through this, that they also have support themselves. I can't underline how important that is, either through finding your own mental health support, turning to your family or community to support you, turning to the resources that we have in our community. And if you're in a partnership, that you work together to support each other, and recognize that you may not always be on your game, and your feelings may be overwhelming, and so the other person may then step in, and you support each other that way. So having acknowledged all these feelings that can come about from this, we want to talk about how to respond, because obviously, even though those feelings are real and valid, that's not necessarily the most productive way to respond. So first and foremost, I think active listening is crucial. That just really listening to what they're saying, listening to what they're experiencing, and as much as possible being non-judgmental and hearing what they're expressing. As parents, you can use grounding techniques. It's a form of mindfulness, which is really anchoring yourself in the present and staying focused on what your purpose is and what you're trying to achieve, and acknowledging that, you know, the emotions can pull you out of that. And grounding is sort of being present in the moment and feeling grounded in the place that you're in. So like grounding, when we talk about that, like sitting on a chair, feeling the chair, you know, just really taking a deep breath and orienting yourself to the present. One method is also counting to 5 and then responding. We, as parents, sometimes, and especially with something this loaded, can become reactive and want to jump in and say something. It's good to stop and sort of think about what you want to say and respond. Give yourself a certain amount of time. Count to 3, count to 5. Balancing your catastrophic worries with what is actually happening. So what are we really hearing? They're saying they want to die. What does that mean? You know, and how can we understand that and help them with that, and not forecast into the future with our own worries about what that might mean. Prepare before launching in when possible. I mean, obviously, these things sometimes most times probably come at the most unexpected moments. So again, I want to say, you know, as parents, we can always repair. You know, we can have an initial response and not feel good about it, but rather than beating ourselves up, model, you know, I didn't respond the best way, and I really want to hear what you're saying now, and I really want to help you with this. And so starting that dialogue, and then developing this family safety plan, including expectations on both sides. And what I mean by that is oftentimes talking about a safety plan is tricky, because parents want to check in if they know their kids are having these thoughts and feelings. You know, of course, it's on your mind a lot. But then adolescents and teens being who they are, they don't want their parents necessarily asking them all the time if they're okay. So what's the dialogue around that? What's the expectation? How do we develop trust with each other? You know, with the teen, trusting that the adult's gonna just ask, talk to them when they need it, and the adult trusting that the teen's gonna reach out when they. Oftentimes this can be done in a therapeutic setting with a mental health professional, to help facilitate this dialogue and articulate what the family safety plan is. And so now onto treatment options. I will talk about psychotherapy and other options, but I want to pass it to Dr. Schwab.
All right. Let me share my screen if possible. Let me pause for just a second as I get this going. Did anybody have any questions on so far on what Adam has been talking about? I'm sorry, I have to do this from the beginning. Please, I'm looking in the chat. I don't see anything right now, but feel free to do that. I know I'd like to hear more about what Adam has to say about what he does to help children. The CBT, I think he's going to get into, but let me because I think everybody would like to hear that too. So I'm going to kind of rush through a little bit of what I'm going to talk about so we can get to that. But if you want me to slow down or ask questions, please do so. Let me start by saying what we do here at NAP. We have what we are developing is called a medical home. And what that means is that we want our patients to be able to come to us for any problem, initially at least, and then we can take care of that problem if at all possible, or refer out to people who can. But at least you don't have to go, if you can come to us first, we can make initial decisions to help you out. And in the past, it used to be people would go directly to specialists, and now that's not only not feasible or possible in many situations, particularly psychological, we also feel that we can do a lot here at our own medical home, because we have numerous now behavioral health consultants. We have, I think, 5. Not all are many are part-time, but we can now help with many of these mental health issues. In addition, prescribers, all of us are trained and have experience in prescribing medication if that is necessary or indicated. So what does a provider like myself do? Well, there are 2 different ways that I can help identify children who have these depressive types of symptoms or diagnosis. The first is we do screenings. I'm sure that you all, when you've come in for physicals, have asked to fill out a lot of these forms, and I apologize for the number that you're asked to do because I think it's very arduous, but yet it is very important because it gives us an idea about the kind of mental health issues children and you may be dealing with, and it may not always come across in an interview. So that's one way we can identify children who have depression, and another is through disclosures from the children or the parents to the provider. You give us a call, you send us a portal message. The next step of what I would do is to ask you to come in, make an appointment, get a detailed history of what is actually going on, what are the symptoms. And then, of course, we have to always assess for safety, as Adam has mentioned. We then do honed down focus screenings, and these are not a way of identifying or making a diagnosis, but it helps us give us an idea of the degree of the symptoms. And I won't get into a PHQ-9 is basically 9 questions that ask different questions related to sleep, depressive mood, difficulty concentrating, and suicidality as well. And then we come up with a treatment plan. Now, the treatment plan is going to be based on, of course, the above, what's happening with your child and these screenings. And then what we do is we kind of divide it into 3 types of presentations. One we call mild or subclinical, and those are children who have some depressive symptoms, but don't require any more aggressive treatment other than something that you can probably do at home. And there's something called a self-management tool, which gives you ideas of how to help them through depressive symptoms, and what you can do and they can do to help alleviate some of those symptoms. The next category is a moderate presentation, and that is children who are more severely affected by the depression. They may be not going to school or having difficulty going to school. They may be isolating themselves, not getting into doing normal activities that they would like to or want to be doing. They may be sleeping all the time. They may not be able to do their schoolwork. These are just examples of a moderate presentation. We know through evidence-based medicine that moderate presentation of depression can be helped for sure, and it usually involves at least some sort of psychotherapy and possibly or likely medication. Then there are the severe forms of depression. Those are the children who aren't going to school, who are actively suicidal. They need to have subspecialty care, which we can refer you to. So how do you explain depression to children? And I'm just going to give you one example that you might use. Because everybody feels sad at times. So that's a normal feelings, they're typical feelings. It's only when those sad feelings become a problem and we feel stuck on them. Stuck is the issue that I'm talking about. Stuck meaning that you can't get out, almost like you're in a hole, or that you're in a snowbank and you can't get out of it, when it causes you to not be able to go certain place that you need to go to. So I would use that as an analogy if you're explaining it to a young child or even a teenager, that sometimes these sad feelings make us stuck. And it's important thing is knowing what to do in order to get unstuck, because it is a problem in the same way. That means, I'm not going to say it's the same way. It's being stuck in a snowbank is a concrete one type of episode. But I think that you can use that as an analogy that you need help getting out of a snowbank, and you need tools like shovels. And this is what actually I think Adam is going to talk to you about through psychotherapy and CBT, it's called, to get unstuck, is some tools to get out of that snowbank. And what we know, though, is that through therapy and medication, 7 out of 10 children with depression will be improved. And that means that there's a lot of things we can do to help. Let me talk to you about what that is. I see there's a chat. I'm just going to look at that to see if that's. Let me answer that at the end, if I can, if that's all right. I'm just going to talk about. I'll get right back to that. Let me just talk a little bit about serotonin. And serotonin is something called a neurotransmitter, and neurotransmitters are how nerves communicate one to the other. Serotonin is one of the most common ones, and we don't know for sure what causes depression. There are many theories, and this is one of them that may or may not be correct in the end. We don't know yet, but it's a nice way, I think, of thinking about what is going on in our brains and our bodies. So serotonin helps our brains work, and there's an area right in here called the limbic system, which is responsible for our emotions. And if the serotonin isn't in as enough of serotonin or a typical amount, then you will start to feel sad or depressed. Now, the thing about serotonin is that, there we go, that serotonin is not just in the brain, it's also all over your body. It's in a lot of serotonin receptors are in your gut and they're in your periphery. So even when you're depressed, and let's say you have a low serotonin level, you get other symptoms. And that's why many times you may have these other types of symptoms that Adam already mentioned are associated with depression. In fact, I might see a child come in with chronic abdominal pain, and that really is just a symptom of depression. And you can see through this chart of other areas how low serotonin can cause physical problems, such as chronic pain, sexual loss of libido, inflammation, chronic pain syndromes. So this is another way in which we know that serotonin affects the body and not just the mind. Let me talk about how we can help. From a provider standpoint, medications can be extremely helpful in children in particular circumstances when we're dealing with moderate to severe depression. And these are the medications that increase serotonin levels. They're called SSRI, selective serotonin reuptake inhibitors, because they increase the amount of serotonin that the nerves are using to communicate with one another. Now, many people have heard of these SSRIs. Many people take these medications themselves. They've been shown in evidence-based medicine to be very effective in children, and these are the most common ones that we use: Prozac or fluoxetine, Lexapro, escitalopram, then citalopram or Celexa, or Zoloft, which is also sertraline. Why would we suggest one over the other? Well, there are many different little peculiarities to one or the other. In essence, all 4 of them work basically the same in terms of efficacy, but there are reasons that we might pick one over the other for an individual child. One might be the half-life, meaning that some are very short in and short out. Zoloft, for example, has a short half-life, whereas Prozac is much longer. Side effect profiles, there's a little bit of side effects, which I'm going to mention in a minute, that are more particular to one versus the other. Some of them are more likely to have medication interactions. So if you're on a medication, we might be more likely to stay away from one or use another. And then there's something called pharmacogenetics, which is how our bodies process or metabolize medications. And we believe that that's certainly based on your genetics. And if a parent, for example, has had a good success with one or the other, I'm more likely to prescribe that one to give that a chance, thinking that the pharmacogenetics are going to be similar between a parent and a child. So how do you explain a medication to your child if we're going to start one? The first thing is I explain the medication is called an SSRI, and it's an effective form of treatment. Let me step back and say that there are variations on this little dialogue based on the age of the child, of course. Sometimes I won't, a very young child, I won't go into much of an explanation at all. It's really mostly with the parent. With a teenager, I would go into a full explanation because they cognitively can understand it. So SSRIs are evidence-based, meaning that they have been tested and proven to be effective through rigorous scientific studies. SSRIs are started low and increase slowly. Our dictum is start low and go slow. And the reason for that is that you will slowly find out if the medication is working and or if there are any potential side effects. So we do this in a slow fashion. SSRIs are medications that need to be taken every day, and they reach their full effectiveness only after about a month. So you have to be on it for a while before we would say, gee, this is or is not working. And we follow patients very closely during this period, particularly at the beginning. And we have a protocol set up so that if I were to start a medication, a week into it, one of our behavioral health clinicians will contact you to make sure things are going okay. And then I see you again in about 3 to 4 weeks. Now, side effects to SSRIs in children in particular are usually very mild. And I'll mention the list of what those potentially could be. But one that most people have heard of is that there have been studies that suggest that it increases some of the thoughts, or it can increase, it usually doesn't, thoughts of hurting yourself. And that's the suicidal thoughts that Adam had mentioned, and on the order of about 3 in 100. But we take this very seriously. And if any of the suicidal thoughts are really increasing, then that's probably something that we need to stop the medication and find a different one. Another thing about children, which I think is important for us to think about, is that SSRIs are prescribed not indefinitely. The idea is to get you unstuck for a period of time until you have tools to keep get the car rolling again. I guess actually a better analogy is to use a life preserver to help you swim. The medication is like a life preserver that helps you stay afloat during a period of time when you can learn the tools of how to swim, and then you can take the life preserver off once you have those tools in place. And that's a very different paradigm than sometimes we think of when we prescribe these medicines, or others do for adults, is that it's more of a long-term thing. We really think of this as trying to help children during a period of time, get them other means of help, and then cut back on them. Another thing to know is that if the SSRI that's first used isn't working, we often can switch to another one, and it often does work. So it does depend on which one you use, but we don't always have a good idea of which one to use at first. And then you can choose medication as the only treatment for depression, but for more severe depression, improvement may be greater if you choose both medication and therapy. This is in the slide that I took from Boston Children's Hospital. And I think that this statement is true, but I think that therapy, which is what Adam does, is my go-to, and that I really encourage everybody to have at least some form of therapy if they're taking a medication, especially starting out. These are the potential side effects, which I'll let you read. I have to tell you that we prescribe a lot in my practice, and it's not common to have side effects from the medicines. They can happen. If they do happen, the most common ones that I see are irritability, which people with depression, as Adam already mentioned, already have, but it can increase that. And if that is happening, we can cut down on the dose. If these things are going to happen, they usually happen starting out the first week or two, and then improve with time. But I can talk more about side effects if people want to ask questions about that. But I can tell you that, yes, these can occur, but it's not very common in kids. This is just some data showing how effective they are, and I'm going to skip that and get to something just to mention that medicines really should not be stopped without a guidance from a provider. If you stop a medication like this, it can give you withdrawal symptoms. So you want to do it under guidance over a period of time, because these are the symptoms that can occur. I want to finish up by saying that I realize that starting treatment for depression, and particularly medications, can sound scary, and nobody wants to have to go through that with their child. But we really want to think about what are the outcomes? What if you don't start help and don't get treatment for depression? And here's a list of things that we know happen when depression is not being treated. It significantly increases the risk of suicide and severe depression. It increases the risk of other medical problems such as obesity, sexual behaviors, problematic social relationships, and occupational educational underachievement. It also increases the risk in childhood, in adulthood, of depression or anxiety and substance use. We know that substance use is often a consequence of, in addition to a cause of, substance abuse. So it goes both ways. And I often see teenagers who are self-medicating with certain substances to help ward off the depressive symptoms. And in actuality, it just makes things worse. So there is a consequence to not treating depression, I'm afraid. So let me go stop there, and I apologize. Let me just read this in the chat. I haven't processed it yet. Somebody did ask one question. I've heard that kids tend to be forthright and honest when asked if they are thinking about suicide or self-harm. Is that really true? Don't they try to hide these ideas from their parents? I would think they would lie about it because they know we would worry. I'll let Adam, you want to answer that one, address that one? How honest are kids about suicidality and self-harm?
Well, I think for most people, it's a relief to have it be mentioned. If it's something on their minds that they're thinking about and they're not quite sure how to articulate it, then having someone just acknowledge that they might be feeling that way provides an opening for them to talk about it.
Any other questions that anybody would like to ask before I turn this back to Adam? Any questions about?
And I only have about 5 minutes left of just talking about treatment options. So I don't know if there'll be questions after that as well, but maybe I should just do that.
Why don't you go ahead, and then maybe some questions will come up, and I have a question for you, but I'll wait for you to go ahead and answer. Tell us about the kinds of work that you do.
Okay. Back to where I was. Where it was. All right. So, so this is just, I got this, I was looking for a way to sort of illustrate the levels of behavioral health intervention. And so the highest being inpatient hospitalization. I will say, looking at this, in-home care is not, I wouldn't really put it there. It does exist, but not sort of at that level. So having said that, inpatient is usually short-term stabilization with medications and symptoms. There's sort of a misnomer that there's a lot of treatment that happens inpatient, and I think that's sort of rare. And really, it's just about a short stay and stabilizing the person. So the next level down would be residential. Although, again, with residential, it can be tricky to qualify for. Often, if you're using insurance, they will ask if the person has tried a lower level first. So the next level under residential would be partial hospitalization. So the thing to say about partial hospitalization is it's not inpatient at all. It's a group, an individual comprehensive outpatient treatment model that really sort of continues in its most ideal circumstance, continues from the stabilization that the person received inpatient. But it can also be used sort of as a preventative measure. So if individual therapy is not working and more intensive treatment is needed, then partial hospitalization can be a good solution for that. It's also done in group work. And I think, especially when we're talking about mental health diagnoses, they can feel so isolating, and being with peers in a group setting that's managed by professionals can really help them feel a part of things. And one of the common things that people say with depression is it feels very isolating. It feels like it's only happening to them. And that can be scary and a lonely feeling. And so group treatment really can address that. Partial hospitalization also does comprehensive work, working on leisure skills, working on DBT or CBT, and what that means, cognitive behavioral therapy or dialectic behavior therapy. And then the next level down would be intensive outpatient, which is less intensive, usually about 3 days a week for 3 hours, but still group treatment. And then the next level down would be outpatient or group treatment through DBT groups, a dialectical behavior therapy group, or some kind of support group, and then individual therapy or family therapy once a week or twice a week. Some support organizations I want to mention for both depression in general and specifically for suicide prevention. NAMI is National Institute for Mental Illness. SAMHSA, which is the Substance Abuse and Mental Health Services Administration from the U.S. Department of Public Health. I want to mention Pioneer Valley Coalition for Suicide Prevention. They provided me with some materials and resources, and which was very helpful. And then there are teen text lines. There are lines that are either operated by professionals or trained volunteers, or in some cases, trained teens who can talk to peer, can provide peer counseling for teens experiencing suicidal ideation or self-harm ideation. There's also an app called Safety Plan, which is very effective. It's free, and it can be found on most app providers. So here are some specific resources for you. And I think that's it in terms of the presentation.
I'm going to encourage anybody to either, you can unmute yourself if you prefer to ask a question that way, or again through the chat. I'm going to ask Adam one question if I could. I want to first make sure that people understand that I think that a vast majority of the patients that I see with depression are able to be treated here at NAP. In other words, they don't need to be into the levels that Adam just mentioned. Luckily, we have them available if need be. But if I see a patient who I think may or may not need medication, but certainly needs help and has mild to moderate depression, and I refer them to you, Adam, can you give our parents here an idea of what does therapy look like? What is it these days? What is it that we do at NAP that might be a little different than other therapists do? And how is that different?
Sure. Yeah. I mean, I think a benefit to what we provide here is usually we can see the family and the child or teen fairly quickly within a couple weeks. Um, and we if the child's 12 or under, we'll usually start with a parent consult. Um, yes, that is the safety app plan. So sorry, someone just put in a question. Um, is the safety plan app also called suicide safety plan? And it's blue with a white plus sign on it. A number of apps are turning up. I want to make sure to get the right one. Yes, actually, let me, since you're bringing that up, I will share that right now. So you can see what I'm talking about. This is it, the Stanley Brown safety plan.
Great.
So going back to what your question, I think we're called integrated behavioral health, and what we do is provide as much as possible immediate support, and we determine with parents, with families, treatment plan, and that can look a variety of different ways. That can be sort of working on one or two goals that that is identified from either the child or teen or the family working together to meet for a few sessions to work on that goal, to learn skills, cognitive behavioral therapy skills or dialectical behavior therapy skills, or offering psychotherapy, just giving them sort of non-judgmental, open place to talk and express. Or we use play therapy. We have a lot of play materials to engage younger children. And then if we're identifying that a greater need is there, we will refer to the community, and we'll help you navigate a very confusing and complex mental health system that that's not easy right now. So we can be there sort of to help you through it, and to support, to follow through if you make a call, to then follow up and just check how things are going. We can't necessarily get anyone into anywhere. We don't necessarily have that ability to just call a therapist and get you in, but we do have relationships with many community therapists and agencies, and try our best to work with them to identify the best place for treatment for you. Is that?
Yeah, thank you. And so we have a couple questions, and let me ask this one that kind of dovetails with that. The question is, what's the difference between CBT and DBT, and how parents are supposed to use this with their teens? Could you explain the difference there and what they are? I think a lot of people don't understand what they are, myself maybe
Sure.
included.
Yeah. So cognitive behavioral therapy is an older model of behavior therapy, using skills and tools to identify the connection between our thoughts and actions, and identify ways to identify those thoughts, those negative thoughts that may be occurring, the assumptions that we make. And this often happens with depression. People that have experienced depression can articulate seeing gray, almost like depression sort of is a weight on you that makes things seem impossible. And we can get into a narrative of being stuck. So cognitive behavioral therapy really works around that. Dialectical behavior therapy is sort of newer, and incorporates the concept of mindfulness into one of its tenets, and it has sort of 4 parts to it. mindfulness, emotion regulation, distress tolerance, and interpersonal effectiveness, which is managing relationships. And this can DBT can be really effective with specifically with self-harm and suicidal ideation, and providing specific skills for learning how to tolerate difficult emotions that feel impossible in the moment, but with repeated experience, people can learn, I can get through this. I can weather this storm, so to speak. And so, so those are two kinds of therapy that many therapists use, that are more kind of directive versus talk therapy, where someone might just be talking about what's going on and the therapist is listening and may provide some insight or thoughts. But these models are a little more directive.
And we you are the therapists at NAP do these kinds of therapy?
Yes. Yeah.
Yeah. And one time somebody said to me that DBT or CBT is you're doing that because you get homework. Is that true? Is that like you give instructions to the parent and or the patient to do things at certain times to help overcome those uncomfortable feelings? Does that make sense?
Yeah, I mean, I think personally, I find homework not the best word. It's I like to say practice, and practice opportunities, and identify what, especially when we're talking about kids and teens, they don't want to go somewhere else for more homework. That's sort of the last thing they want. So, so more the idea is like, what do they identify that they want to change? And are there opportunities to practice that in their lives? We can identify. And are they willing to practice this in this certain, or is the family willing to take this and practice this at home in this circumstance? So I wouldn't necessarily call it homework, although that is a term used in CBT. I would say it's really important that they identify they're motivated to do it, and then we can go from there.
Great. Let me ask, I'm going to read a question that's in the chat. My daughter's closest friend talks to her often about having suicidal thoughts and seems very withdrawn most of the time. My daughter says it doesn't bother her that her friend speaks about these things, and she is happy to help her friend, but I worry it will affect her. Are these ideas of how I can support her during this time? So in other words, the daughter's friend is the one who's having suicidal thoughts, and mom is wondering what she can do to help her daughter.
Yeah, I mean, I think having an open dialogue about it and letting your daughter know, like, if you ever have these thoughts, I'm here to talk with you, or I would like to help you find ways to talk about it. But if the daughter is saying that she's not having those thoughts and she's not exhibiting some of the things that we've talked about in terms of symptoms or warning signs, then it may be that she is there for her friend. She's supporting her friend through this. Now, I think friends are really important in terms of supporting teens with depression or suicidal ideation or self-harm, but I think it's also important that professional is involved if it's at that level, so that someone who's trained to identify when to intervene and how to intervene can support that person's family and support system. Does that? Yeah.
Let me ask another question about teens. With a teen, I find it hard to find out what is going on, as I am trying not to ask questions. I am assuming that it just might have to be that way, and that I will be contacted if I need to during therapy. I mean, I guess she said, I think, and maybe she can clarify this, is saying that in therapy, the teen isn't talking to mom about things. Do I have that right?
Well, so he's, he's going to therapy, recently identified. I just, I don't have, because he's over 13 and his privacy rights, I just don't know what's going on in therapy. And so, uh, and he's not a kid to talk about it. So, and I don't want to ask him if he's okay all the time, just like you recommended not. So is it just that I have to sort of, if it's more serious than just he needs to sort of, you're figuring this out, that I will be contacted by you folks. And otherwise, I just have to sort of live in the unknown and be available to talk if he wants to talk.
Well, so one of the aspects to confidentiality and HIPAA is that we inform people that we're working with that, most of what we talk about is confidential. The exceptions are if the person identifies wanting to harm themselves or someone else, or we're also mandated reporters. So if we hear of child abuse, we do have to report it. So those are exceptions. So a therapist would have to let you know and whoever else know if they had someone who they thought was at risk for harming themselves. That being said, I think it's worth talking about with your child and therapist, like clarifying, what involvement you have. And if they're saying they really want it to be private and they really want it to be for them, then respecting that and seeing, if you're seeing a change in them and you're seeing that that hopefully the therapy is having an impact.
Yeah, let me ask a question, a follow-up on that then. I mean, if a parent of a teen wants to talk to the therapist, who the teen's in a therapeutic relationship, they can call the therapist and the therapist can get permission from the teen to be able to talk to the parent,
Right.
Number one, right?
Right.
And number two, they can also give you, I think a lot of parents, I imagine, would like to just get an idea of, are things okay? Are things going in the direction that the therapist thinks they should be? Are there more things I should be doing as a parent? So is that okay for parents to contact the therapist of a teen and say, how are things going?
Yeah, again, right. Yeah, I think, but I think just being upfront about it, in terms of, I would like to reach out to your therapist, or seeing if they would be open to meeting with you and the therapist together, just to talk about what you feel comfortable talking about. So when I meet with teens, I assure them that I'm not going to go tell them everything. I mean, tell their parents everything that they're talking about. However, I will, some of the work may be, well, how do we communicate this to your parents? So if it's something that needs, that's going to help them improve by opening a dialogue with the people in their lives, then that's one of the areas of work is, how do we do that? How do you do that? But I think especially with teens, it's also really important that they feel safe and they feel like they are not going to be reported on, for sharing openly. That's part of how therapy can be useful, is the person being direct and really sharing what's going on with them.
Mm-hmm. Please continue to put in the questions if you have any. I'm going to ask another one because this happens for a number of my patients. I work with teens, and a lot of them are not interested in therapy. They are they're resistant to doing therapy, even though I've encouraged them, and maybe their parents have as well. Often they do. Do you have any hints of things that parents can say or do to help their children get help?
I think that's a really nice aspect to our department here, integrated behavioral health, is it can be a sort of introduction to therapy. Because we don't work in a traditional model where we do weekly appointments and expect that. I think that's a tricky thing with finding community therapists, is that there's a level of commitment that you have to make to get a spot to see a therapist. And if the teen or child is not motivated to do that, then they may not be able to keep that spot because they're not, they may either refuse to show up or would not be consistent. And so with our model here, we can do one session where I've had plenty of sessions where I've met with a parent and a child or a teen and just talked to the parent while the teen or child listened, and just sort of let them see, what's this about? Who is this person? And explained and tried to get them to articulate some of their concerns about doing therapy. And so, so that's one method I think is using this IBH department that is part of NAP to have your teen or child just see what therapy is like, ask questions from a therapist, try 1 or 2 sessions and see how it goes, and then go from there.
Yeah, that's right. It is, there's a less of a hurdle when it's done in the same office that they've gone to their whole lives sometimes, and for every other medical care. So it does normalize that. And I think it does reduce the hurdles.
And as you're saying that, sorry, John, I see there's a question,
Yeah.
but I just want to add
Right.
another thing that we do. We don't just do appointments. We actually have time where we're on the floor. So you may have a well visit, and that is another time where we could just come into the well visit and do a brief introduction for the child or teen and meet them that way. And that's even less pressure than making an appointment, because we'll just walk into the room and we'll talk with you for a little bit. And so I just want to also put out there that we do that as well.
No, that's a good point, right? And yeah, so if parents are just coming in for a routine checkup and they have some concerns, they can even ask if there's a behavioral health consultant clinician available to just come in for a minute and get a sense of what's going on.
Exactly.
So the another question, is it normal for teens to prefer socializing with friends on chat and video games? When they do get together, they have a good time, but don't like making plans. Pandemic socializing, in other words. Yeah. You want to answer that one?
I think that's yes. And well, for better or worse, it's only been encouraged by the pandemic to connect in these other ways, because it was really, I think, useful for families to have teens connect when we couldn't connect in person through these other methods. And for teens, it's convenient, and playing video games with your friends sometimes is what teens want to do. And so I think that's very common, and so I think, again, it's a topic for a family conversation about screen time, about connecting, and encouraging them to connect in person as well as just through a screen. And but I think also, yes, teens don't always make plans. Sometimes they wing it for the weekend. But if they can sort of challenge themselves to meet in person as well, and not just through a screen or through their phone, I think that's good modeling for being a well-rounded person with a social life.
Great. Okay. Any final questions before we say goodbye? I will thank Adam for being here and for giving us some education on what depression is. And I thank you all who attended and hope that this was helpful to you. And I'll encourage you to talk to your providers, if you have concerns about your kids, we are here. It is a pandemic. We are overwhelmed, but really, this is our job. This is what we want to do. This is what we want. This is why we're here, and we're going to do our best to help take care of the kids in our community. And we know that mental health issues, depression in particular, is really rampant. So I wish you all the best in taking care of your kids. And thanks, Adam, for
And I'll
joining us.
just say, if anyone wants a copy of any resources, you can reach out through your provider and ask them to message me through the portal, and I can get those to you.
Great.
Yeah.
All right. Thanks, everybody. Adam,
You are welcome.
can you hold on for just 1 minute? I just want.
Yep.
Thanks. Oh, and thank you, Lauren.
Thanks, Lauren.
All right. Okay. I just wanted to wanted to thank you again. It was a great presentation, Adam. I learned things, and I appreciate your putting that together. I think it was, we had a decent number of people, and I think that I really would like to see how many people do the recordings, because I think, for me, I think this is the kind of stuff that we need to be doing in order to reaching out to our patients, because it's too overwhelming for many people to make a phone call or come in and to learn about this. So I thought it went really well, and I think people were engaged. Any thoughts that you wanted to expand upon?
No, I guess I would just say, I mean, I think now that there's more of us, it would be nice. It's